This is a typical way that is expected in the future exam when you have got a big stem of the question and images. A 20-year-old female presented with complaint of intermittent pain, abdomen, loss of weight and loss of appetite since 6 months. She now has abdominal pain after a heavy meal. On examination, abdomen appeared to be minimally distended with diffuse tenderness in right upper quadrant and periumbilical area. Patient underwent a barium study and the study is given to you here, which is given below. To investigate further, CT of the abdomen was also done and you could see a sagittal reconstruction of the CT scan. Where exactly will be the site of obstruction in the given condition? So now what is happening? A clinical condition has been described which is supported by the radiological investigation, and now you have to give a further information about the disease. Now what you could see in this barium meal study, the stomach is markedly dilated and the proximal duodenum. Stomach and proximal duodenum is dilated, and that means there is an obstruction that is happening somewhere in the duodenum, and as it's clear from the choices. Now what you could see in the sagittal section, you could see the aorta, and what is this artery that is originating from the aorta and going downward is superior mesenteric artery. So now if you go back to your anatomy, you know that the third part of the duodenum passes between the aorta and the superior mesenteric artery. Now normally this artery has an acute angle with the abdominal aorta, and this angle is usually around 45 degree. There is a range, but it's usually around 45 degree. However, in conditions like this is a condition which is called as superior mesenteric artery syndrome, or commonly called as Wilkie's syndrome. Now what is happening is when the patient does not have enough of a mesenteric fat, now this angle become more acute, usually around 6 to 10 degree. So this compresses the duodenum, and which part of the duodenum? Which is passing between the aorta and the superior mesenteric artery. So the answer is third part of duodenum. This is third part of duodenum. So the question has got a radiological information, anatomical component, and as well as a lot of clinical information. Integration is the norm that is happening nowadays. So this is a third part of duodenum. Next question. A 3-year-old child presented with cough. Please note 3-year-old child. Cough, fever and breathlessness. A diagnosis of pneumonia was made and child was adequately treated with antibiotics. A follow-up chest radiograph to look for resolution revealed the following finding. All the following statements are false except. Now this is an extremely important part. That means you have to tell the true statement. You have to pick up the true statement. Now let's look at the chest x-ray. Now what do you see? It says pneumonia. In a pneumonia, I should see a consolidation, but I don't see any consolidation because it is resolved. Now what I am seeing is a thin-walled air containing lucency. A thin-walled air containing lucency, which is nothing but in a 3-year-old child who had a pneumonia, this is nothing but a pneumatocele formation. This is nothing but a pneumatocele formation commonly seen in patient who had staphylococcal pneumonia infection. So now let us see the statements related to this. It is an emergency condition and need an emergency intervention. No, that is wrong. These are self-limiting and no emergency treatment is required for them. Antibiotics should not be stopped but should continue for a long duration of time. That is also wrong. They are self-healing. I mean, once the primary infection has been taken care, they resolve spontaneously. Positive pressure ventilation increases the risk. Indeed, that is a true statement. It has been seen that those patients who have been put on positive pressure ventilation, there are more chances of developing pneumatocele in these patients. Later transform into a chronic cavitary lesion. No, these are self-limiting. The chances of converting them into a chronic cavitary lesion is extremely rare. So the answer is positive pressure ventilation increases the risk. Again, a lot of mixing of the subjects that is happening over here. Now, the take-home message is in these kind of questions, please pay attention to the age of the patient. Please pay attention what has been asked. So this is false except, that means true statement has been asked. Next question. A 36-year-old male patient with a BMI of 41.5 kg per square meter. So that means you're trying to say that the patient is morbidly obese. Presented with progressive dyspnea since 10 days. Patient is known case of dyslipidemia and is currently on fibrates. On examination, he has increased BP, heart rate, tachycardia, respiratory rate 16, SpO2 is reduced 93% in room air. Systemic examination did not reveal any specific finding. Chest radiograph was normal. Further evaluation, a cross-sectional imaging is done. What is the diagnosis? Now, what do you see? You are seeing a contrast enhanced CT scan in mediastinal window. You could see the opacification of all the vessels. You know this is descending aorta, this is ascending aorta, and this is pulmonary artery. This is pulmonary artery, and what do you see? You see the filling defects in the pulmonary artery. And if you have filling defects in the pulmonary artery, the first diagnosis that should come to your mind always is pulmonary embolism. So this is a classical CT scan image of a pulmonary embolism.